We will have someone for the next meeting.
I'm sure you will, Jeremy.
I will keep quiet now. Thank you.
Thank you.
Okay, welcome to the Staffordshire Health and Wellbeing Board this afternoon, which the meeting is streaming live and also will be recorded, so members of the public will be able to view the meeting from the website. So I'd like to welcome all members of the Health and Wellbeing Board and also any members of the public who have joined us today. Okay, so in terms of apologies, we've had apologies from, lost my list. I've got it now, sorry. Apologies from Dr. Rachel Gallio, Craig Porter, Gary Jones will be late joining the meeting due to a clash of meetings. Philip White and Jonathan Price is joining us as a substitute for him, and Jennifer Mattison will only be attending between 3 and 4. Okay, so if I could first turn to members to ask if there are any declarations of interest pertaining to the items on the agenda. Tim?
Thank you, Chair. When we come to item 4A, Together Active, I'm a board member for them.
Okay, thank you. Okay, and so if we could first of all turn to the minutes of the previous meeting. In order to agree the minutes, sorry, before I do that then, Johnny, have you got a question?
It's not a question, it's just that there's a typo in the minutes I just want to refer to.
Oh, right, okay.
But I think it's quite important because it's confusing. There's okay. 3, it says on the second last paragraph on page 3, 3 ICSs, when it should say 3 ICPs, I believe. Have I got the right?
The place of the board and the system is
yeah. Well spotted,
yes, 3 ICPs. Yes, it
should be Ps. Should be partnerships. There's there's one system and 3 partnerships.
That's right. 1 ICS and 3 ICPs. Yes.
Yeah.
Okay.
Thank you.
So I won't go through each page. I won't turn each page. But are there any other parts of the minutes that colleagues would like to would like to challenge or would like to comment on? So I've got Johnny. Your hand's still up. Have you? Is there something else?
Nope. No, there isn't.
No. Okay. Thank you. Okay. So if we're happy with the minutes, then I will agree to sign those minutes off as a true record of our meeting. And if I could now turn to matters arising from the minutes. So on page 4, around the partnership review, Helen Riley, could I ask you to update the Health and Wellbeing Board, please?
Yes, Chair. I guess due to the lockdown that we've been in for some time now, this hasn't progressed at speed, but there has been a discussion between myself and John Topham around how we take this forward. And the plan is to engage partners in a wider discussion, really when times are a little calmer in the spring.
Okay, thank you very much, Helen. Okay, and in terms of other matters arising, We did agree as a Health and Wellbeing Board, following a questionnaire which was sent out to members the back end of 2020 to look at what our priority areas are going to be, and as part of the matters arising, we wanted to focus on obesity, which is one of the areas, as you will see from the papers, that we're focusing on today. And we've also scheduled a focus on mental health for the June meeting, which again will tie in with the progress on the mental health strategy. And Adults and Children's Safeguarding Partnership Board Annual Report is on the agenda today, as we agreed in the last meeting. Okay, so in terms of questions from the public, as far as I'm aware, we haven't received any questions from the public. So, John, could I ask you to confirm that?
I'm not aware of any, shall we put it that way? So, yes, I don't think we have.
Okay, thank you. Okay, so if we could turn to the first main agenda item, which I'm going to ask Richard Harling to present. It's a presentation and an update on living with COVID.
Thank you, Chair. I shall see if I can share my screen in a second. Chair, are you able to confirm that that's visible?
It is visible, yes, Richard, yes, it's there.
Thank you. So there's a relatively brief presentation and an accompanying paper just to highlight what I believe may be some of the issues that face us over the ensuing months and years. First of all, I think it's safe to say that we are going to be living with COVID for many years to come. The virus has become endemic. I do not believe that we are going to be able to eradicate it, and therefore it will be circulating in our communities probably in perpetuity. That means that we will need to maintain a series of what I've called COVID defences, and hopefully we will have control over as many of those as possible at a local level. I think the future is quite uncertain. There are a wide range of plausible scenarios, which I'll try and touch on in a moment. And whilst we should all hope for the best, we just need to make sure that we are planning and prepared for the full spectrum of what might befall us. There are a range of impacts arising from the pandemic and also the response, both on, for the purpose of this presentation, are focused on the Council, but these conclusions apply similarly to probably any reasonably sized public sector organisation and probably businesses as well. I think there is an opportunity at the moment to generate a bit of debate about some of the challenges and opportunities and try and build consensus about what sort of things we take forward. And again, we've had some discussions at the Council internally, and this is an opportunity for a wider partnership discussion. So the components of local COVID defences are here. And I think that these are things that we will need to maintain under all plausible scenarios. So the first one is testing, contact tracing, isolation and outbreak management. We'll need to make sure that we have facilities available for testing both people with symptoms and regular asymptomatic testing for as many people as possible, as frequently as possible. We are going to need to maintain contact tracing to follow up all cases, find out where they may have contracted infection, identify others who may have been exposed and make sure that we can isolate them. I hope that we won't be doing it at quite the scale we've been doing it for the last few months, but nevertheless that requirement will remain. Isolation of cases and contacts is currently at 10 days each as a legal requirement. Again, I expect that to continue. From the evidence we have, most people do appear to be following that. We are at the moment referring suspected non-isolators to the police for follow-up, and again, very grateful to police colleagues for their role in that. I also expect that there will continue to be outbreaks of COVID in various settings. Again, hopefully rather fewer than we are seeing at the moment, but there are some settings that remain innately vulnerable. So anywhere where large numbers of people share a small space gives an opportunity for the virus to spread. And whilst uptake of vaccination at the moment is very good, we can expect, I think, that there will be pockets of our communities where uptake is suboptimal, and that will give an opportunity for a resurgence of the virus. Again, hopefully these will be small and infrequent, but we need to maintain the ability to deal with them. Secondly is COVID security, and by this I mean a minimum level of both personal and environmental hygiene, as well as a degree of social distancing. Again, under best case scenarios, I don't think that needs to be as intrusive as it perhaps has been over the last year, and might fall under what we would regard as sensible precautions, not dissimilar to other routine health and safety measures that we tend to observe at home and in our workplaces. COVID vaccination. So it seems likely that the virus will evolve and that new variants will emerge, and that the vaccine will need to be updated and re-administered on a fairly regular basis. I think annually is a reasonably safe assumption, and that would be a similar principle to the flu vaccination, which is re-administered on a yearly basis. And finally, we will need to make sure that we're supporting the most vulnerable people. In Staffordshire, we have 50,000 people who fall into the clinically extremely vulnerable group, and to whom additional support is available with things like shopping, collecting medicines, all those sorts of things, just to make sure that they can stay at home should they need to do so. All of that will need to underpin by very good public engagement and communication to make sure that these messages are getting across. In terms of scenarios, so I've said that the range of plausible scenarios is broad. Do bear in mind that these papers were prepared about 3 weeks ago, and in those 3 weeks, the most likely scenario is moving to the left. So it is getting more optimistic rather than less, which I think is a welcome thing. Nevertheless, the situation does remain extremely volatile. At the moment, the new variants do not appear to be causing a significant problem, but there does remain the risk that those take off as lockdown is released, and that some of those might compromise the vaccination. So under best case, you will have seen the roadmap set out on the 22nd of February from the government, with some indicative timescales about when restrictions might be released. I think everyone is hoping that we are able to progress with that sort of speed, and that societal restrictions can be lifted without putting undue pressure on the NHS. And then once they're lifted, that they stay lifted. An optimistic but still best case scenario is that because of the emergence of new variants, the vaccine isn't quite as effective as we'd hope, and that the virus sort of re-emerges potentially during winter, and that we might see a need for perhaps some low-level restrictions imposed seasonally. Again, I wouldn't anticipate that they are anything like as intrusive as a lockdown, but we might see through those some sort of impact on the well-being and the economy. And then a more pessimistic scenario whereby new variants compromise vaccination effectiveness quite significantly, and that COVID defences are overwhelmed, and that might see significant restrictions being reimposed with a more significant health and economic impact. Again, just to stress that we do appear at the moment to be heading towards the more optimistic end of that, and let's hope that it stays that way. In terms of the impacts, so a whole range of them. This first slide is on organisational impacts. So we have seen throughout the pandemic an extraordinary response from all sorts of public sector staff being willing to rise above their normal duties and to do whatever it takes to try and control the spread of infection. And certainly from the council, we want to encourage and reward that, and make that a routine way that people work, I think. I think the other thing is that people have been hard at it now for over a year, and we do need to make sure that we protect staff well-being and make sure we have sufficient capacity in 2021-22. In terms of operating model and digital, so all sorts of opportunities from the pandemic to shift some of our services and interactions online, to review our requirements for estates, and to continue new ways of doing things that I think have proved quite beneficial over the last 12 months. Demand for public services, I think, is more unpredictable than I can ever remember. In things like demand for the NHS and social care, the high levels of demand that we've seen over the last year or so may actually be ongoing. I know the NHS has got an awful lot of catching up to do with delayed elective work and has got a real challenge to get back to that. And we may see sequelae from COVID infection, the sort of syndrome of long COVID, as well as the consequences of prolonged isolation for people on mental well-being that I think health and possibly social care services will be dealing with for some time to come. In view of that, we are going to need ongoing funding from the government, and I think the budget that we heard earlier this week was probably less helpful than I think we may have hoped for on that point. On a positive again, I think the pandemic has accelerated partnership working in all sorts of helpful ways. And again, I think that's something that we would want to sustain, and from local government build on that as an opportunity to make the case for devolution of duties and powers from central government. Finally, some reflection on the impacts for wider society. Again, you will have seen this week in the budget statement that the economy has taken a heavy hit over the last year, and there are all sorts of businesses that I think will continue to be affected, particularly those businesses that rely on face-to-face interactions. For schools and universities, there's a year of lost learning to try and recover, and potential challenges for the future, particularly for universities. I know the student experience over the last year probably hasn't been what students have been hoping for, and if that remains suboptimal, then I can see universities becoming less attractive than perhaps they have been hitherto. In terms of health and well-being, I think it's inarguable that the pandemic has damaged quality of life. We've got early evidence that mental health problems are rising, and that the things like inactivity and diet and obesity have deteriorated over the last year. And a lot of those other social and lifestyle determinants of health are heading in the wrong direction. And I think we have a real challenge ahead of us to try and turn that corner in the year to come. Climate change, so some potential benefits in terms of reduced road traffic, possibly some downsides about the sustainability of public transport in the wake of ongoing requirements around hygiene and social distancing. Communities, more of a positive, so there's been a huge surge in volunteering during the pandemic and an opportunity to harness that in the longer term. And then social cohesion, again, in the more pessimistic scenarios, I can see, unfortunately, some tensions starting to arise between those who want to prioritise protecting the NHS and those who are more enthusiastic about returning freedoms and livelihoods more quickly. And I think there will be a role, if we get those scenarios, for the public sector to facilitate some of that debate and perhaps mediate between those different views. I'll stop there, Chair. Thank you.
Thank you very much, Richard. That's a really good summary of, what we've been facing and what we've got to face in the future. And as you say, we'll be living with COVID for some time. So if I could ask if there are any questions for Richard. Roger Lees. Roger, I think you might be on mute.
Yes. It's time today.
You're there now.
Vaccinations, I just want to speak a bit. Are we getting the supplies needed for all of our communities, or is there some disruption in any areas?
Thanks, Roger. So my understanding is that the supply chain is improving. It was a little bit erratic initially, but I think over the last few weeks it has definitely got better, and we're starting to see a steady and improved supply of vaccines coming through. The promise and expectation is that we will get to around 80,000 doses per week over the next few weeks.
Thank you.
Thank you, Richard. Okay, so I've not seen any more hands go up. So if I could thank Richard then for that update of where we are, and it's clearly highlighted some risks and sort of emerging inequalities that as a Health and Wellbeing Board will need to support and work with our system partners to address. So that is going to move us smartly on to invite Tony Bullock in, who is going to present the Public Health Strategy Plan, and then we'll be joined by colleagues Karen Coker and Jude Taylor to focus on the obesity and the physical activity.
Thanks, Chair. Can you hear me and see the slides that I put up?
Yes, both great.
Fabulous. Okay, the first session around the public health plan should be relatively brief, but is designed to segue hopefully seamlessly into the obesity discussion. But in terms of this first session, I'll quickly talk through the purpose of bringing this today, a little bit of context. We'll talk about the priorities that we've got in the long term and the short term, the approach that we're taking, and then some recommendations. Okay, so we, as a public health and prevention team within SCC, we're developing our strategy, and the purpose really today is to share our thinking with you, to have a brief debate, but really to start or kickstart that broader consultation. So we're not presenting a strategy that we've developed and agreed. It's just those initial ideas that we want to get your input from the very early stages as we develop it over the next few weeks and months. The strategy, or any strategy that we produce, will be designed to contribute to the wider Health and Wellbeing Board strategy. We certainly intend for everything that we produce to be consistent and complementary with the Health and Wellbeing Board, and similar with other partnerships such as the integrated care systems that we're working with wider partners in a collaborative way. So again, the priorities are very similar to those that you'll recognise. Healthy life expectancy isn't what we would want it to be. Infant mortality is a priority for Staffordshire. We're an outlier in many ways. And health inequalities, I'm sure no one needs reminding of the differences that we've got in Staffordshire. I think it's worth sometimes as well reflecting on the levels of inequalities that we've got and the levels of deprivation that I think are sometimes masked by the size of the county, and that we've got real pockets of deprivation that sometimes aren't recognised by central government in the way that funding's allocated. So there's some issues there that we need to get a grip of in the long term. In the short term, the key programmes that we're working on to deliver those longer term objectives, clearly the response to the pandemic is our key issue that doesn't need explaining. I'm sure members are aware of the supportive communities piece of work. I think Richard mentioned in his slides the fantastic volunteering that we've seen over the last year. And I think that's really helped to support that piece of work. And helps to create an interface between public services and community-led organisations to benefit one another, particularly in terms of preventing people requiring adult social care and intensive health services. So that will continue to be a priority. Mental well-being as opposed to mental illness in the sense of trying to generate health and well-being as a preventative factor is something that we haven't invested a huge amount of time and effort in historically. But again, picking up on some of Richard's comments in his presentation that there is some early evidence that mental well-being is deteriorating, and we've started a piece of work that we see as a big priority going forward to try and improve well-being and prevent mental illness. And then obesity, again, similarly, has always been a priority, but is more so given the impact of the pandemic, and we're going to be discussing that in more detail after this presentation. So these are our emerging ideas as priorities. The approach for the public health team, clearly we've got a leadership role. It's our specialist area. We've got staff with a great deal of expertise in the subjects, but we see very much our role as coordinators. I think commissioning has changed very much over the last 20 years. It's not about teams doing everything in particular areas, but drawing together the various resources that all partners and stakeholders have. So the plan isn't that the public health and prevention team will achieve these outcomes in isolation, but will very much work together with other partners to try and achieve the outcomes that we all wish to seek. Clearly, there are different target audiences, and the way that we've segmented the population there is really looking at the state of people's health and well-being. And we want to do primary prevention in the sense that we want to ensure that people remain healthy, and we facilitate and try and encourage the conditions to help people to be healthy, such as living in dry, warm homes. But we also want to work with some people who've got some unhealthy habits, but aren't becoming unwell. So the secondary prevention, so trying to encourage people to exercise, eat a healthy diet, quit smoking, reduce their alcohol intake. But there's also a group of people that are unwell, but we want to try and support them from losing their independence. Very much the supportive communities work that we talked about earlier, and trying to link people into social groups to reduce loneliness, improve people's quality of life. So different approaches for different parts of the population. And then we've got lots of different methods to try and improve people's health and well-being. Again, commissioning's moved on from very much focused on funding services of specialist workers to try and achieve outcomes. The approach that we're taking is trying to look at lots of different resources, encouraging people to help themselves by giving good advice and information and making the most of the digital technology that we've got now. The communities that we've already talked about have got a big role to play. Partners have all got resources and ability to reach people and to change behaviour, but also there's also a key role for services going forward. But the trying approach that we want to take is to coordinate all those different resources and have a blended approach to achieving outcomes. And the example from my background, most of my work over the last 20 years or so has been in drugs and alcohol. But I think it's a useful example to look at that kind of collaborative approach. Public health are responsible for drug and alcohol treatment. The budget comes to us. We've got specialist members of staff, but they don't do everything. We coordinate an approach with police, probation, social care, housing organisations. Lots of people benefit from this approach. Lots of people have got roles within that. And we want to try and take that approach with other issues as well, which are perhaps less obvious that suits a partnership approach, like obesity, which we'll come on to shortly. So recommendations really for today, just to try and get comments from the group about those initial ideas for our plan. We'll be seeking feedback over the coming weeks before coming back to this group at a future meeting with a better developed strategy, and really just seeking a commitment from partners to contribute to that public health programme over the coming months and years. I'll leave that slide, that's the final slide, but very much really would just want to get the input from members on those initial thoughts for our plan.
Okay. Ooh, Echo. So, okay, Tony, thank you very much, and thank you very much for that summary of where you are with the plan. And in terms of those recommendations, would you like to take any comments now?
Yeah, be very interested in any feedback. As I say, we'll be starting to consult over the coming few weeks, but be interested in any thoughts that anybody's got today. Okay, so can I ask if anybody would like to comment on the plan that Tony's presented today? So I'll take Johnny first, Johnny McMahon.
Thank you, Chair. And thank you, Tony. That was excellent, and I fully support this. As you know, the one thing that strikes me is we think we know what the outcomes of coming out of COVID are going to look like. We just don't understand the scale of them. But I think we might see. I think we've got to have a more open mind about that, because I think we might see stuff that we don't understand now coming out of COVID. Yeah. So I just think we've got to have our ears to the ground, so to speak, so that we pick up the issues. I mean, we know about mental health, we know about increased weight, and we know about increased alcohol in the home. But there could easily be other things that are floating around the place that yet we haven't quite taken on board. But the approach is great. Thank you.
Thanks, Johnny.
Thanks, Johnny. And if I could bring Gary in now, please. Gary Jones.
Yes, thanks, Chair. Tony, we've had lots of conversations about this, so we're broadly supportive of the approach. I'm sure members of the board who will have read the health and care white paper cover to cover will have spotted an interesting paragraph buried deep in the paper, which makes reference to bringing public health commissioning outside of public contract regulations in the same way as some of those freedoms are available to NHS commissioners currently. So I guess it's more of an observation really than a question that that's sort of gone into the white paper, I guess on the basis that it makes it more flexible and sort of you can tailor things more locally. And my observation would be that would fit very well with this approach and make it easier for the council to work in a bit more of a flexible way.
I was worried you were going to test me on an obscure paragraph from the white paper there, so I'm quite relieved that it was a comment rather than a question on an obscure point.
Okay then, right. Thank you. So okay, so thank you for those comments. So before we move on, Tony, I'd just like to say again, I'm very supportive of this approach and like to see very clear priorities. So if I could ask colleagues and members of the Health and Wellbeing Board to reflect on this and give feedback, anything further to Tony. And the plan is to bring an updated, more detailed plan back to the June Health and Wellbeing Board. Tony, can you share those slides with the board?
Yeah, Liam's got them, so I'm sure they'll be shared with the papers.
Okay, thanks very much. Okay, so Tony, I'll let you introduce Karen and Jude and.
Okay, have the next set of slides come up?
They have, yeah.
Okie doke. This is a joint piece of work. I'll introduce the first couple of sections and then bring Karen and Jude in. And this is the main piece today. That was just the starter, really. This is the section that we really want to get your input on. And some of there's a bit of good-natured provocation. We don't want this to be a presentation that everyone just kind of agrees and nods through. We really want to get your input on this. So there's a few questions in there to try and get you thinking in a good-natured way. Okay. doesn't always work in this remote setting, but hopefully it will. Okay, so we'll talk a little bit about the purpose of the session. We'll give you some background, and then we've got 4 or 5 questions that we want you to think about around obesity, and particularly your roles as representative of your organisations within that. We'll tell you a little bit about the whole system approach, which is what Public Health England are recommending for obesity, and then we've got a few requests at the end. So we're having a look at those questions that we want you to debate as we go through. Okay, you might spot a couple of poor puns in here as well. There were going to be more. So you've been spared some of the worst ones. It's a very easy area to create puns in, but we really want to see if the Health and Wellbeing Board has got the appetite to drive this as an agenda. We'll talk about why it's a priority, but we very much want to get your buy-in into this and play an active role in the obesity agenda going forward. We want to explore a little bit about what's gone wrong previously. Karen's slides will talk about the state of obesity and physical activity in the county. There have been lots of exercises in the past. There's no shortages of opportunities to exercise and eat healthily, but we're still in a situation that I don't think any of us would want us to be in. And then we want to debate very much about what we can do going forward, individually and collectively. So a real thinking session today, with the hope of getting you to buy into this as an approach. Okay, at this point, I'll hand over to Karen, who is very much our expert on this. So hopefully, Karen, you're there to take over.
I am there. Thanks, Tony. So yeah, we're going to give you a bit of background. I'm not going to sort of labour some of this too much, because I think, to be honest, we're probably all really quite aware of the problems around obesity and the consequences of obesity, but we've got a few brief slides here around this. So this is the latest figures available across all of Staffordshire. So we've got nearly 25% of reception age children, so 5-year-olds, are overweight or obese in Staffordshire. And I think off the top of my head, I believe all 8 districts are above the national average in regards to that. We've got we've got a third of year 6 children, so 10 and 11-year-olds who are overweight or obese across the county. And again, I think there's 5 districts that are above the national average. We've got 2/3 of adults who are overweight or obese. And I think that's 6 of our districts, I believe, are above the national average in relation to that. And then we've got a 1/5 of adults who are physically inactive across the county. And again, I think we've got 5 districts that are higher than a national average in terms of that. So paints a bit of a bleak picture, really. And I mean, obviously, that's just 1 year's worth of data, but, you know, we have got the data available to us for a number of years. And as I think we all know, it's not an improving picture, particularly. It's, if anything, it's getting worse. If you can move on to the next slide, Tony. So issues linked to obesity, again, as I say, I'm not going to labour on some of this because we know it really, but increased risk of diabetes, heart disease, certain cancers, respiratory issues, the links with mental ill health, which I know was something that was one of the priorities in Tony's earlier presentation. The links around COVID, so there's lots of research coming out in terms of, you know, you're more at risk of developing COVID if you're overweight or obese, and then you're more at risk of having poorer outcomes if you do then contract COVID. And then there's the wider issues that aren't around sort of health as such, around the sort of impact on education and employment. So, for example, linked to probably mental health as well, and linked to sort of ill health, there's the impact upon education in terms of, you know, non-attendance and so on, and also then the link to employment in terms of unemployment. It can adversely affect that. So there's such a wide range of consequences linked to obesity. And then there's the cost to the individuals themselves, to organisations and the economy as a whole. One of the papers that we've pulled together, because I think there's 2 papers linked to this item, the paper that's around a whole system approach, talks about there being a cost to the NHS of £6.1 billion per annum I think that's from 2014 to 15. I think that was the latest information available or that we could find. But there was also a link to kind of social care budgets as well. And that was estimated to be 352 million per annum. So it's pretty significant in terms of the cost to individuals themselves, but also to organisations and the economy. And although we've had obesity as a priority in many local and national strategies and plans, you know, it's been a priority for the Health and Wellbeing Board. It's been a priority for the Family Strategic Partnership, the Troubled Families Programme. You know, there's lots of things where it's identified as a priority, and individually we're doing lots of things. And I'm not saying that those things that we're doing aren't having an impact, but they're not having enough of an impact, and we need to do something differently, because if we keep doing what we're doing, we're just going to see the same increase in obesity rates and all of those consequences that come as a result of that. Next slide, Tony. And I think I hand over to Jude here, actually.
I think that one might be me, unless Jude desperately wants to do it. But is that you, Jude? Sorry.
Yeah, okay. So this is one of the first of the discussion items we've got for today. And as Tony said, some of this is meant to be deliberately provocative, but we really want to hear from you with a really kind of honest perspective. And the first question that we've got here is about, is the current position good enough? As Karen outlined, this has been an issue for a number of years, and it's something that we haven't really got a hold of locally. And I suppose the question is that reflective of the fact that actually day to day this isn't a priority for us, that this isn't something that's impacting work areas, creating pressure? Are we satisfied with the status quo given the other priorities that are presented in themselves to us and our partners? So I'd really like to hear thoughts on that.
Okay, so if I could ask colleagues to raise their hands if they want to give some thoughts on that. I've still got Johnny and Gary's hands up on my screen, but I'm not sure whether they're still up.
The legacy hands, but I would like to speak again, if I may, at some point, Chair.
Okay, Gary, is yours a legacy hand?
It's not up on my screen, so.
I know. I think it's my screen, but I tried to put them down, but I couldn't. So, well, Johnny, I'll invite you in then to give a view on that. Then, first of all.
Thank you. I think this is extremely difficult. I read recently from a well admired source that more folk now die of the effects of overeating than they do of starvation in the world, which speaks volumes. And the developing world taking on Western habits and a Western culture means that it's spreading all over the place. We do live in an obesogenic society, and that's why the whole system place-based approach makes sense. And we've got to look at the lives people lead and what we can do to modify behaviour, rather than simply concentrate on the individual trying to sort themselves out, because we know that simply doesn't work. I think we've got to be. I also think this needs to be done in the context of being healthy, not just being overweight or obese. The Great Fat Chat, which I think was in 2014-15 or so, it went down very badly in Cannock, because people didn't like being told they were being fat. They felt they were being lectured to, and whatever we do here, we've got to be sympathetic to the fact that people are in a very difficult place with this, and having a work environment which makes you sedentary, having home commitments that means it's difficult for you to get out, not knowing how to cook, thinking so much is out of your reach, either in terms of time or in terms of skill, to live a healthy life, is not the fault of the individual. And it's a real structural approach that involves both districts, counties and the NHS with the County Council to sort this out. The second thing I would say is I think there's a real risk here, and the voluntary service. Gary, apologies, and there's another issue here and I think that we can rely too much on exercise. There's a great mantra that says we cannot outrun fast food, and it's all to do with making good, healthy, nutritious, with low calorie density food available and cost effective to people, and giving them the opportunity to write exercise into their day. That will sort it, but it's a huge challenge. Thank you.
Thank you, Johnny. And I think in my answer to that question will be, no, it isn't good enough. And we do, the way to tackle this is really on a place base and all working together to support this. So, Karen or Tony, can I ask you to continue?
Should we move on? Apologies if there's anyone representing Tamworth there. I'm sure that headline was very frustrating and possibly unfair, but was there really just to provoke you in the good-natured way that we described earlier. I don't think Tamworth is particularly different from many other areas, but got that unfortunate moniker from the Daily Mail a few years ago. Okay.
Sorry, can I just butt in? Gary's got his hands up.
Right. Oh, sorry. Yeah, it's just popped up on my screen, Gary.
Thanks. Yeah, and I don't know where this comes in. I don't know if it answers this question or the next, really. I mean, endorse absolutely everything that Johnny said. Again, I don't know why I'm going on about the white paper, but there was some stuff in there around advertising, which is welcome to see, but not nearly enough, if you ask me, because I think that is a huge thing that we're up against, for all the kind of pleading that advertising doesn't make people fat or unhealthy. Well, it's obvious, isn't it? You wouldn't put so much money into it if you didn't sell more of the stuff that you're trying to sell. Everybody knows the logic of that. But the other element I wanted to bring into the conversation was, which is why just having seen the second discussion point is perhaps more relevant there. I think we oughtn't to underestimate the role played by food in making people feel good when they have a lack of other feel good and meaningful things in their lives. And I think, if there's anybody on this call who wouldn't admit to having had a chocolate, cake, whatever, when they've been feeling a bit down, then they're probably not being honest with themselves. So I think that kind of mental well-being element is really significant.
As someone who's put on quite a lot of weight in lockdown, I'm perhaps not the right person to be hosting this next slide. But yeah, I think there's a lot of evidence for what you've mentioned there, Gary, that people use food as reward in the same way, but perhaps to a lesser extent, that people use opiates. And it's a similar sort of pathway in terms of addiction and recovery. But yeah, the second point, whose responsibility is this?
Tony, can I just, Johnny's got his hand up. Was this, Johnny, did you want to come in before Tony moves on?
Sorry, yes, it was only to take up the point of Gary mentioned about obesity in the white paper. It's all about the watershed for high salt, fat and sugar content food. Being has to be more than 9 o'clock in the evening, which is all very well, but it does nothing about mobile devices and kids being on smartphones and iPads and all the rest of it. And that just shows what an extensive, difficult problem we've got here. It shows just how all-invasive and why a whole systems approach is so important. That's it.
Thanks, Johnny. And for the other members of the group, Johnny and I have talked about this before, and the similarities between obesity and smoking, and the sort of structural issues and the long-term approach that's required. That around 15% of adults smoke now, but in the 80s and 90s, that was more like 50% of the adult population. And there was no silver bullet answer that has helped us to achieve the results that we've seen, but a consistent and persistent multi sort of factorial approach that uses lots of different levers works for smoking and is a public health success. But we probably need a similar sort of long-term approach that is consistent, that we haven't before. We've had lots of approaches that we've kind of dipped in and out of, and we've got to be persistent if we want to achieve the success with obesity that we've had with smoking. It's going to need a similar multi-pronged approach. But segueing into the second discussion point, then, so whose responsibility is this then? Is it for the public health teams? And there are various teams that sit under that umbrella in adults and young people and partners such as Together Active, or is this genuinely a priority for everybody? Now, I'm sure we all recognise it's a priority, but is it something that all the partners around the table recognise as a priority for them and have got a contribution to make too? So really, putting that out to the wider group, is it a priority? Because there are competing priorities at the moment, and everyone's strained and has got a huge amount to do. So is it a priority for all, or is it only a priority for us public health teams?
So, in response to Tony's question, then challenge, who would like to, would anybody like to come in? Tim Clegg.
Yes, thanks, Chair. I certainly hold my hand up and say, on behalf of the district councils, and I'm sure the county council too, we see this as a priority for us. Very much welcome the more holistic approach to tackling obesity. I had some grave reservations about the big fat chat. I see the tackling obesity as being part of a much wider agenda. I think the agenda for today's Health and Wellbeing Board suggests, along with exercise. Clearly, we need to make it as easy as possible for people to make healthy choices, be that around taking exercise and creating an environment where people can do that, but also where they can make healthy choices about food. I think we need a cultural change in this country about what we see as being a treat in terms of eating, and really to push back against a lot of processed food that manufacturers wish to put in our direction with the higher salt and fat content that they often have, and particularly around fast food choices, which seem to be treated or seen as a treat for families, which I don't think really helps in terms of bringing children up to make healthy choices. Clearly, there's a link between health inequalities, obesity, and poverty, and we can see that in the figures from public health. And I think there needs to be some more work done to understand that and to identify good practice from other places that may have successfully tackled that, because clearly, as Tony suggested, we need to do something different. That may not be that there's a magic bullet that will solve this issue. I suspect there isn't, but there must be a concerted effort across a wide range of fronts to tackle that is consistent and prolonged, and does involve an honest discussion amongst partners about what we can do to make some very real change there. Thank you, Chair.
Thank you, Tim. Johnny, is yours a legacy hand again?
I took it down. Chair.
Oh, as I say, it's obviously my screen. So, I mean, I think my comment will be, I mean, obesity, the challenge of obesity cuts across everything, doesn't it? So I think really It's certainly when we've had discussions at the Health and Wellbeing Board, we have, it's been put as one of our priorities, and I think we have it because it cuts across everything, cuts across all our organisations and health and care. Really, we've all got a part to play in it, so I think it does need to be a priority for all. And now we've quite clearly seen the impact of that. The impact of obesity and the fallout and how that impacts people on an individual level and on a society level as well. So, okay, Tony.
Okay, should we move on to the next slide? And before we go into why we think past efforts have failed, there's a bonus point for. I found out today the name of the character on the screen that I'm sure anyone with small children will probably be familiar with, and a certain ex-Beatle. But does anybody, other than the person who needs to remain silent to begin with, know the name of the character there?
Well, it's Fat Controller, isn't it?
Controller, yeah.
But he's got a name.
Oh.
I only found out today.
Is it Ringo?
It's Topham Hatt, isn't it?
It's Mr. Topham Hatt.
John Topham was very pleased that we'd use the character today. So one of his distant relatives.
Can I just say it's Sir Topham Hatt? I'll have you know, not just plain old Mister.
Okay. I think is this your slide?
No, it's over to me, Tony. Yeah, it's over to me. But I mean, we've probably touched on a little bit of this, haven't we? Because we've, in terms of why past efforts have failed. Now, I've been in my current role in children's public health for 18 months or so. So things like the big fat chat, for example, that Johnny's already mentioned, sort of were a bit before my time. So I've probably got my own views on why I think past efforts have failed, but we just wanted to throw that out there for other people to sort of suggest why they think we haven't made much progress on this so far.
Any comments from anybody as to why we've failed in the past?
Mark Sutton and Johnny's got his hand up again as well.
Okay. Johnny?
I think in the past we've been judgmental. I think the term "the great fat chat" it implies that. I think that it's we need to consider it in terms of health as a whole, not just simply being obese. And we haven't done that. I think we need to concentrate more on food and less on exercise. The issue of exercise is hugely beneficial, even if you don't lose any weight. In doing it, it's still beneficial, but in itself, it's not enough. And the harder end is to, the easy thing is to try and outrun fast food and fail. The harder end is to do something about what our residents eat. So to my mind, the whole system approach, which we haven't had to any extent before, is the right one, because we have to change things in such a way that that it's easier for people to adopt a more straightforward and healthy life. We have health in every policy at the moment at the County Council, and I believe the districts have that as well. I'm not sure. I believe so. I thought there was a risk that we'd pay lip service to that and not really deliver on it. I don't think that's the case, but on the other hand, I'm not sure we take it really seriously enough. It's as if we take a negative approach to it. I think we look at something and say, well, this policy doesn't make people's health worse. Rather than looking back and saying, well, what is there in this policy that we could perhaps adopt or change that could make people's health better? I think there's two ways of looking at that, and I don't think we look at the latter enough. Thank you.
Thank you, Johnny. Can I bring Mark in now, please? Mark Sutton.
Great, thank you. I just wanted to talk a little bit, I suppose, about not necessarily why what we've tried to do has failed, but give an example of something that we've done in society that's been a real success, and that was the move to prevent drink driving. There is a time, if we go back to the 60s, that I can remember as a very small child where, you know, there was no taboo about drink driving. I can remember my father and uncles all getting together when we used to go to my grandparents' house and all going out having 4 or 5 pints and then all driving home because it was the norm and it was what was done. And really there was no obvious consequences to that. But over the years, drink driving have dropped considerably. It's not something that's been eradicated, you know, but they have dropped considerably. And part of that has been the information available, people seeing the consequences, the adverts that were run about people in hospital dying, their relatives speaking about it, and also the fact that the consequences, if you were caught, are instant. You're almost automatically banned from driving for 12 months. Your insurance goes through the roof. It can be very difficult then to get another job while you're disqualified if you lose your other one. There are instant consequences. Overeating, there's no instant consequences to it. It's something long term, absolutely, and it has a monumental effect. But people don't necessarily see the things that far in the distance. So I think that's one of the fundamental difficulties that we have. And I'm not providing a solution here. I'm just giving a scenario that has worked. And I just wanted to pick up a little bit on what somebody commented on before about. There being obesity in children and it being linked a little bit to poverty. Well, I think Karen will confirm for me that the figures in South Staffs show actually the complete opposite, and it's not necessarily just linked to poverty, because the majority of South Staffs, being quite a relatively affluent area, has got quite a large incidence of obesity amongst children. Thank you, Madam Chairman.
Thank you. And so could I bring Helen in now, please? Helen Riley.
Thank you, Chair. Just building on the points that have been made, really, why have past efforts failed? I think there is a point really linked to what Johnny said around the perception of the state lecturing people. And I just don't think that kind of approach works. I've shuddered over the years as I've signed, individual letters to parents telling them their children are obese and that we have to do something about it, which has been a kind of national children's public health requirement, which to me is absolutely the way to get parents on the wrong side before you start. I think it's been too campaign driven. I think Tony's points around successful campaigns previously around that constant going at it, really, and not giving up, and a multi-pronged attach, which includes around the quality of food that we eat, that Johnny says is really, really important. But what we're doing all the time is firefighting, aren't we? At the moment, for years we've talked about adults being obese and children being obese, and so we have to deal with that as fat fighting, I suppose, rather than firefighting. But in terms of the future and future generations, and thinking whole system, this absolutely has to start, I think, with pregnancy, with maternity, and support to families as soon as children enter the world, to work with them and alongside them to understand nutritional benefits, and access to open air and exercise, in its contribution to mental health and general good health, in a preventative way, because I think that's the only way we solve the future. Otherwise, we'll always be dealing with today and the problems of today.
Thank you, Helen. Tony, can I hand back to you? Yes, please.
Okay, Jude, is this for you? I've lost track of who's who.
It can be, Tony, yeah, that's fine. I think actually we picked up on a lot of what needs to be done differently to make a greater impact in this area, but is there anything else that we need to reflect at this stage? Any kind of real general observations about how we need to alter our approach if we're going to be effective in this space?
I can't see any hands up, but please, can you shout if your hand's up, because I'm having all sorts of problems with the hand function.
Are we all going to become more thorough and do lots more exercise and eat a lot more salad? What is it that we can do potentially to that's different from what we've done before?
I wonder, Tony, whether the reality is the discussions that we've had so far, people seem to be really kind of endorsing that whole system approach. So I don't know whether we just skip on to the next discussion points because I'm conscious of people's time.
Yeah. Yes, please. Yeah, as you say, I think we're endorsing that it is about working together and having a consistent message, isn't it?
Just to say, Phil's got his hand up. Phil Pusey.
Right. Okay. Right. So yes, Phil. Okay. Can I bring you in?
Thank you, Alison. I was just going to say, I wonder, have we utilised, I know in other areas of where you're looking for culture change and you're looking to make impact, we've used lived experience of people that have come through this and come out the other side with a positive story to tell. And I just wondered if that's something that had been considered within the whole approach.
I think that's a very good point, Phil.
I think that's a really good point, and I think when we come on to some of the later slides about whole system approach, I think that would be one of the kind of actions, if you like, that sits under that.
Okay, so should we have a look at the final discussion point?
You're ignoring Gary again, Tony. Gary's got his hand up.
Oh, sorry, I can't see hands.
I can't. Yeah, Gary.
Sorry. I guess it's implied, but whole system also needs to mean whole person. So, and again, building on Phil's point, I strongly suspect those stories don't start with individuals who are now lighter in weight and healthier, saying, oh, it's because someone told me how to eat and exercise more. They probably talk about being happier and more fulfilled in general. So that, that's just the implication really of the whole system approach.
Okay, thank you. So if we could move on.
Okay, so the final discussion point, and it's really just to ask whether is this something that the Health and Wellbeing Board can really get its teeth into, and apologies for the puns, but is it an opportunity for the Health and Wellbeing Board to really show that it's got an influence and that will hold partners to account to deliver what we need to deliver on this, and really throw the weight of influence that you all have behind this as an exercise?
Okay, so as chair, I'll take my privilege and certainly state that clearly we have already agreed that this is one of our priorities. So if it's one of our priorities, then clearly I think we need to be completely behind this. But could I ask colleagues if they've got if they disagree with that point, just to sort of raise their hand or shout, or is it our opportunity to show that we have got teeth? I think silence means assent there, Tony. Agreement.
Okay. Right. Well, I suppose the proof of the pudding will be in the eating, to use another bad pun, and we'll see over the course of the coming months and years how we all fare in doing this. Okay, let's move on then I think Karen, this is one for you, isn't it?
Yeah, there's just 2 or 3 more slides to go, and I won't. In fact, I won't spend very long at all on this one. So this is just the Public Health England's definition of a whole system approach. And it's simply about working. This isn't about doing a project. This is about a different way of working. We are not going to, in terms of managing expectations, we're not going to see miraculous results in 6 months, a year, even 2 years. And so I think that's what we've got to really understand from the get-go, because what we want is, we do need to be consistent and we do need to be persistent, and it is a long-term approach and not a project. So, other priorities are always going to come along, but unless we really stick to this and work at it, we're never going to make a difference. So that's just the definition of a whole system approach. This is, and I know you probably can't see this very well, so I won't go through it in detail, but this again, Public Health England with the Association of Directors of Public Health and the Local Government Association and Leeds Beckett University have come up with a guidance document, a real step-by-step practical guidance on how to implement a whole system approach to obesity. There's 6 steps to it. So the setup phase, building the local picture, managing the local system, actions, managing the system network, and then that constant reflect and refresh. So that's their sort of step-by-step guide. Just to let you know that what's happened so far is that from a county council point of view, we've already discussed this with Cabinet. We've identified 2 very senior champions for this within the local authority. So that's John Henderson, our Chief Exec, and Councillor John Lee McMahon. So there are our champions within the local authority. We've set up a co-working team, which is, at the moment, it's primarily SEC colleagues, but that could be something that obviously can be widened out, to do some of the doings, do some of the initial work. So we've been working our way through phases 1 to 3, working with our insight colleagues to look at the data. We've contacted initially our district council partners to talk to them about this and to get their view on whether they've got, as Tony said, whether there's an appetite for this. All 8 district council partners are committed to this and interested in it. We've talked about having 2 pathfinder areas, just in terms of getting the ball rolling in a couple of districts, just to sort of take some of the learning. We had 6 of the 8 district councils who were really keen to be pathfinder areas. So we've ended up sort of selecting, if you like, 3. So we've gone with the Cannock district, East Staffs district, and Staffordshire Moorlands, and there was various reasons for that. East Staffs, one of the reasons being high levels of physical inactivity amongst adults, but also thinking about the BAME community in East Staffs. We thought, so we've got 3 very different districts that we want to start this in. And we are following the guidance, the Public Health England guidance, and we're kind of leading up to doing stakeholder workshops in each of those 3 districts with as wide a range of partners as we can, to looking at what the root causes of obesity are in those districts and doing a system map about those root causes. And that will lead us on to phase 4, which is around the sort of action planning and us collectively deciding in each district, which actions to focus on, what could be some of the quick wins, and then obviously what are the longer term ones, but what are the things that we could do collectively together that are going to have the most impact. So that's the way we're sort of approaching it, and that's the kind of work we've done so far. So our request for this is that, 1, that you endorse it, which it sounds from what the conversations we've had so far that you are behind this. To perhaps invite members of the core working team, so that includes myself and Tony and Jude, we're all members of the core working team, to invite us to some of your organisations, meetings, for us to kind of provide some information about the whole system approach and to gain that commitment. We would really like for each organisation, not just from the Health and Wellbeing Board, but much wider, we'd really like a senior or strategic champion in each organisation, and then a more operational lead to help us to make this happen. This is about, we've talked about these things for years, but it's about making it happen. So it's about walking the talk, if you like. As a very minimum, it's about committing to ensuring a healthy workforce in each of our organisations. And it's about the Health and Wellbeing Board agreeing to become that system-wide governance for the whole system approach. And just finally, before we finish, just to say that We did speak to some of the other local authorities who were involved in putting that Public Health England guidance together and who've tested this approach. So we have been taking some of the learning from them. And interestingly, some of them have used this framework to do a whole system approach to poverty. And I've been on a call this morning actually around the whole system approach using the same model around mental health. So it's quite a tried and tested method that other local authorities and other areas are working on, and not just about obesity. And I will leave it there. I will shut up now.
Okay, thank you very much. So can I just, is that the end of your presentation? Yeah. Yeah. Okay. So that's great. So can I ask the Health and Wellbeing Board then? Are we in agreement to support the request that Karen's just gone through and that's on the screen? Again, I think that's a thumbs up. I think one comment I would say is I think this also will sort of nicely fits with the next agenda item around integrated care systems and that partnership working as well. And I think it's how this all links as a whole system approach, how moving into integrated care partnerships and primary care networks, how we all need to work together on this agenda. And it's really an exciting way of moving forward and to really harness that working together that we've seen work so well through the COVID pandemic. Okay, so can I thank Tony, Jude and Karen very much for that really interesting presentation and leading that discussion, which I think has been really good. And I think we've come out with an agreement of a way to move this forward. But clearly, what we'll need to do is get a sense check of progress that we've made. So if I can ask John to make a note that we have an update at a future Health and Wellbeing Board.
Yeah, make sure that happens.
Yeah, thank you very much.
Thank you.
Okay, thank you.
Thank you.
Okay, so if I could now move on to and welcome Paul Taylor and Marcus Warnes and Tracy Shewan, who are joining us now to update on the the plans for the integrated care system and the way forward and what the future holds for health and care going forward. Okay, so who's leading the way?
I'll make a start if that's okay, Alison, and I will get my crystal ball out and come across all Mystic Meg over the next 5 minutes or so. So I think we've got a 15-minute slot. We're just going to, I think there's a really good, concise paper which also references colleagues to the more detailed papers that have been sort of published over the last year or two that informs our journey to becoming an integrated care system. Paul is with us. Paul is the STP Finance Director. I think Simon Whitehouse, the STP Director, would have been here. He's on leave at the moment, so Paul's drawn the short straw. Tracy is the CCG's Director of Corporate Services and Communication, and also fills that role for the STP. So just to pull a couple of, I guess, headlines out of the paper that's in front of you, it does set out our journey to become an integrated care system. It's very much based upon our current STP, Sustainability and Transformation Partnership arrangements. The ICS will include all of the partners that are currently members of the STP, and we already have a shadow ICS partnership board in place. The initial recommendations for ICSs were set out by the NHS in late 2019, and it very much built upon the proposals in the long-term plan for the creation of around about 40 ICSs based upon STPs. A discussion paper was published by NHS England in late November of last year. A feedback was sought, I think, by the 8th of February, and it put forward a number of proposals, one of which was to put ICSs on a statutory footing, which was very different to what was proposed in 2019, for them to become effectively statutory bodies. The white paper that the government issued last month adopted pretty much all of those proposals and did propose legislation for ICSs to become statutory bodies and to effectively take on the responsibilities currently carried out by clinical commissioning groups, and also some of the commissioning responsibilities that NHS England carry out, things like primary care, specialised services, prisons, veterans and military health, are sort of moving into ICSs. We submitted our ICS application on Christmas Eve. We haven't yet heard the outcome of that, but Staffordshire and Stoke-on-Trent are one of the 13 STPs that have yet to have their ICS application approved. The idea is that all those applications are approved from the 1st of April 2021. ICSs won't become statutory bodies until April 2022 at the earliest, and the proposal in the white paper is that there would be an NHS body and a wider health and care partnership, so two components to ICSs. And effectively, I think the NHS body would become the statutory organisation that would take on the functions currently carried out by CCG and some of those functions that NHS England carry out. For Staffordshire and Stoke-on-Trent, underneath the ICS, we're proposing 3 places. There's no place won't be legislated for by the government. It's up to us to decide what makes sense to us. But we do have integrated care partnerships already on the north, the south east and the southwest of Staffordshire, which brings together health and care partners. The proposals that we set out in our application was a lot of what we currently do once across Staffordshire and Stoke-on-Trent will be delegated down to, along with budgets, to those ICPs to carry out on behalf of the ICS. As part of this, we had to bring together the CCGs so that there would be one strategic commissioner. So from the NHS perspective of commissioning, that means that we would go from 6 CCGs to 1. The legal vehicle for doing that will be merger. Our member practices voted for that last month, voted to merge the CCGs, and we are going to be submitting an application to merge the CCGs by the end of March. At the moment, we're looking at an in-year merger from the 1st of October. So essentially, we would still have 6 CCGs operating for the first 6 months of next year. They would come together on the 1st of October, and then pending the legislation from the 1st of April 2022, the CCG functions would be subsumed within the NHS statutory body. Still some work to do in terms of the relationship between ICSs and health and wellbeing boards, which are obviously statutory subcommittees of local authorities. And we'll wait to see what the legislation says about that and the further guidance that's issued in April. But a very close working relationship between health and wellbeing boards and ICS is very much envisaged. So the paper sets out in summary form where we are, what we're planning to do, and when we're planning to get there. So I'll probably pause at that point, Chair, and take any questions.
Okay, so are there any questions for Marcus?
I have to say it's an excellent paper that in 2 sides of A4 that Tracy summarised very well where we're going. So I think if that's answered all your questions, then great.
Richard's got his hand up.
Yeah, thanks. More of a comment than a question. So obviously we've had a look at the white paper, which signals the statutory bodies, and the thing that's called an ICS Health and Care Partnership Board. It sounds quite a lot like a health and wellbeing board, to be honest. So the idea of creating a unified plan for NHS social care and public health could become a crowded space. So just need to make sure we're not tripping on each other's toes. I think from a local authority, we're less clear about the role of this ICS development plan for the next year. This idea that we apply is a very NHS-y thing. It's not a statutory requirement, it's an NHS England requirement. So I think we're still a bit unclear about how we fit into all of the things for next year, and we're probably focusing on implementing the legislation as the bill comes through in whenever it is May and then becomes an act. Thanks, Chair.
Yeah, if I could just respond.
I was going to say, Marcus, can you respond to that?
Very happy to. So, yeah, I do agree with Richard. There is no one size fits all to this. And certainly the conversations with the centre were that in some areas they will be using the Health and Wellbeing Board, where they have one across the proposed ICS as their ICS partnership board. So questions were asked around, can we use what we have? And I think the view back was, yes, you can. You could certainly consider that. I think the problem we have across Staffordshire and Stoke-on-Trent, well, it's not a problem, but what we currently have is 2 health and wellbeing boards, one for Stoke and one for the county, which might be a bit of an issue for us. So what we have done effectively is taken the STB board and partnership and used that as the basis for the ICS shadow board. Richard's absolutely right. This could be a very crowded space if we're not careful. And I think we were probably not expecting there to be 2 ICS boards. So the Health and Care Board, Partnership Board, and also a unitary board for the NHS organisation. So I think some questions that we hope would be answered in the further guidance that comes out in April and the legislation that will work its way through the House in May around some of that. And Richard's also absolutely right. This is quite NHSE in terms of applying. So a number of us have just come off a pre-merger meeting, so we have to apply to merge. Despite that very much being the direction of travel, we have to apply to become an ICS. So they are quite ICSE things, and there are criteria you have to meet. Sorry, NHSE things, and there are criteria you have to meet to be signed off as being an ICS or being a merged CCG. So it does, I think, feel quite NHSE at the moment. A lot of the feedback that's gone back has been that it needs to be stopping an NHS thing. If it's going to be true integration, it needs to have a much wider focus than just the NHS components. I don't have an answer for that at the moment, Richard. We're going to have to work with you and the City Council and the other local authorities, and indeed other partners, on how we make this something that's relevant to everyone, not just an NHS thing. So, yeah, completely agree with everything you've said.
Thanks, Marcus. Any other comments or questions at this point?
Johnny's hand up.
Johnny?
Thank you, Chair. I concur with Richard's thoughts entirely. I mean, I think the Health and Wellbeing Board, in the time I've known it, has had a series of identity crises, not quite knowing what it wants to do, and its function, largely because I think its statutory requirements are quite limited. And if we just take out the preceding discussion about obesity, where should obesity sit? Should it sit with the Health and Wellbeing Board, or should it sit with the NHS Partnership Board? It's not straightforward, and we're going to have more and more of these, and it's not particularly helpful, because if it's such a big important issue as the whole obesity epidemic is, then if it sits with one, where does the other fit in? And I think that there needs to be some understanding and configuration here, and the idea that it's both is just silly. So we need to do some work on that. And I think when we think about it, we've got to think about policies that are cast iron rather than just the theory of it. So where should obesity sit, and what should that mean for the other party? Thank you.
Marcus, do you want to respond to that?
Yeah, so I think I was very careful at the end of my opening statement to say that we need to do some more work on how the ICS and the Health and Wellbeing Boards align, come together, and I guess what sits where. I think Johnny's made a good example of one area where I couldn't answer that question at the moment. Johnny, no. I mean, at the moment, Health and Wellbeing Boards are statutory bodies, statutory subcommittees of local authorities. ICSs won't become statutory bodies until, assuming the legislation passes, until April 2022. So I think we probably have some time next year to work those kind of issues through and try and determine what makes sense for us. But I don't have an answer for that at the moment, Johnny. No, it's something we need to work together on collectively next year, I think.
Okay, thank you. So, Paul, did you want to come in at all?
No, I'm fine.
No, you're fine. Okay. Yeah. Tracy, do you want to come in around the merger and the survey?
Yes, okay, so thank you, Chair. So as part of the CCG merger, and again, it is an application process, as Marcus said, we have had the vote with the GP membership, which we have to have. That is our requirement, and is very much the yes or no part of whether we can apply or not to be a merged CCG. However, we do want to engage with our stakeholders. We do want to hear what our stakeholders have to say about CCG's merging, and on that we have published a questionnaire that's gone out to stakeholders to ask for their comments really, and what do we need to take into account, and some of what's been raised already I think is really important, what we take into account as we go forward with CCG mergers. But it's really interesting to see, and we've had it open a week so far, what the public say, and some are just saying, well, why don't you just get on with it, and see the reasoning of, we think you'd do this anyway, why have 6 when you could have 1? But I think there is that importance as well, is to make sure we recognise the localism, and actually taking forward the CCG into a merged situation allows those ICPs to flourish, and we must make sure we take that into account. So hopefully we can seek some feedback from our stakeholders to say what's really important and what do we really need to make sure we get out of the merger as we go forward. So yeah, we'll talk to stakeholders. The stakeholder survey is out there, and we'd welcome anything, and certainly welcome anything from this committee that would help inform us how we take things forward.
Thank you, Tracy. So it doesn't look like there's any more comments or questions, unless I'm corrected. So Marcus, you look like you're going to...
Yeah, Alison, if there are no more questions, I was just going to, I guess by way of a closing comment, would say that Prem Singh is the independent chair of the ICS, so Prem has been appointed to the role. There will be further changes needed over the course of next year to make in preparation for the ICS. We've talked quite a lot here about the ICS as a thing, and the changes in the architecture and organisations. There's a lot more in the white paper and also in the NHS document that fed into the white paper, which also merits consideration around the emphasis upon inequalities, tackling inequalities and prevention. There's a lot in there around clinical leadership of systems. There's a lot around integrated commissioning between the NHS and local authorities. There's quite a lot in there as well around provider collaboration. Whilst there's nothing around provider configuration, around how providers work together on a place level. There's also the fact that NHS England and NHS Improvement will formally merge. So there's a lot more in the legislation, and also stuff that grabbed the headlines around the Secretary of State sort of taking some control back for the NHS and wanting to intervene earlier in reconfiguration programmes, which may or may not have implications for the work we're planning on doing when it's safe to do so around the STP consultation. And there are some big issues in there that we'll be consulting on later in the year. So this is a fairly seismic sort of reconfiguration, reorganisation of the NHS, which pretty much unpicks most of the landscape reforms that led to the Health and Care Act of 2012. Quite a lot in there as well around exempting the NHS in terms of clinical services from having to go out to tender and procure services. So there are some pretty significant changes in there. We've probably barely even captured the flavour of that in this conversation. So I think it would be helpful. I'm sure Prem would want to do this for the ICS as it evolves and develops, to engage with both health and wellbeing boards to bring stuff back on a regular basis, so colleagues are fully informed and engaged in the process that we'll be going through over the course of the next year.
Thanks, Marcus. So we've been asked as the Health and Wellbeing Board to consider the information and act and endorse the direction of travel and proposals to become an integrated care system. And as Marcus says, I think there's lots more sort of work and information to come out and to work out as a system across Staffordshire and Stoke-on-Trent how we all work together, and how the Health and Wellbeing Boards and the integrated care partnerships and the integrated the ICS and ICS partnership board, how that all fits together, and we need to work that through as a system. Okay, thank you very much.
Thanks, Alison.
Okay, thank you. Bye.
Bye.
Thank you.
Thank you. Okay, so thank you. So if we can move on to the next agenda item, and if I can welcome John Wood, who's going to present the safeguarding adult safeguarding report with a focus on learning disabilities, which we did receive the report in December, John, at the Health and Wellbeing Board, but welcome you today to present it with a focus on the learning disabilities. You're on mute, John.
Yeah, sorry. Thank you, Chair, and thank you for the opportunity of attending today. I am joined by Ruth Martin. I can see Ruth's initials there, so between the two of us, we'll cover this agenda item. I know that you're busy, so I shall go through this fairly quickly for maybe 2 or 3 minutes just to set the scene and then hopefully stimulate the conversation. But by way of introductions, for those that don't know me, I'm the independent chair of the Staffordshire and Stoke-on-Trent Safeguarding Adults Board. And today I bring the paper that hopefully you've had the opportunity to read. Ordinarily, I would have brought the annual report, but this time there's a different focus, concentration on something which is of, I would like to think of, mutual concern, and it's to do with health inequalities for adults with learning disabilities dying from COVID-19. That is the thrust of this paper. The covering paper has embedded links to 3 documents, one from the CQC, one from the Learning Disabilities Mortality Review, otherwise known as LEADER, and a report from Public Health England, all fairly chunky reports. But they report the findings of national research into deaths of adults with learning disabilities who died from COVID-19 at, it's fair to say, a premature age. And there are various estimations there of those death rates, which equate to about 6 times more likely than the general public or general population. As far as the paper is concerned, the Health and Wellbeing Board and the Safeguarding Adults Board have a mutual interest in ensuring that there's a clear prevention programme to improve health and wellbeing, and of course reduce ill health in line with the health and wellbeing strategy, as well as a commitment from all partners to the prevention programme, and that's very much about what the essence this is about. It's about prevention. This is a hot topic nationally. I think you would be reminded that there's been a lot of debate around health inequalities more generally, but it does include people with adults with learning disabilities. And Joe Wiley, notable radio presenter, has campaigned for the early vaccination of adults with learning disabilities, and that is already in train. And I know that work is already going on in Staffordshire, which is really good news. So these matters, I would suggest, will be of interest to the Health and Wellbeing Board as part of the transferring care priorities that link directly to the LEADER programme. And the premature deaths of adults with learning disabilities may well be a matter for consideration for the Joint Strategic Needs Assessment. As the paper illustrates, the Health and Wellbeing Board is asked to consider the findings of those reports with a view to initiating activity to understand the causes of the disproportionality and indeed actions to tackle the determinants. I should conclude by saying that this was a matter discussed at the Safeguarding Adults Board in January. There was quite a debate. The role of the Safeguarding Board in this particular context was to recognise that the reports nationally had highlighted particular findings and to ask the questions as to what was going on in Staffordshire and indeed in Stoke-on-Trent. And whilst some assurances were given, there were also some concerns around certain activities of a prevention nature. For example, health checks were not being done well necessarily in all cases. You know, a figure about half of adults with learning disabilities have got up-to-date health checks. There was a need to ensure that health passports are used. And again, we had examples of some adults with learning disabilities being discharged early from, in some cases, hospital settings and then gone on to die earlier. I'm not necessarily saying that all those things have happened in Staffordshire. I think there are some gaps in information, but hence the reason for bringing it here today is to just ensure that it's on the health and wellbeing radar and that the Health and Wellbeing Board take their part in seeking some assurances and indeed the people around this table will have more of an active interest in this agenda than necessarily they would be around the safeguarding board. But I'd like to think that there is general support for us to look more, to lift the stone and look more into this, rather than just leave the reports as they are. It just feels very uncomfortable just to leave them without necessarily anything being done about that. Ruth, you've sat there patiently whilst I've just made my introduction. I won't say anything now for certainly unless there's a question for me. But Ruth, do you want to add anything to what I've already said, please?
Not too much. For those of you who don't know me, my name is Ruth Martin. I'm the Adult Safeguarding Team Leader for Staffordshire County Council, and also officer to the Safeguarding Board. And this was obviously a report that raises, some questions that we need to be clear in the answers around what support we are giving within our local communities for adults with learning disabilities. And I think that it is just about making sure that there is that awareness widely through all partner agencies, and as the work of the board is to seek those assurances, we're hoping that we can gain some of that assurance from today's meeting.
Thank you, Ruth. So members of the Health and Wellbeing Board, have you any questions or comments for John or Ruth? Right, I've got Johnny's hand gone up, and that's the only one I can see at the moment. So Johnny, can I bring you in?
Richard's got his hand up first, and he may be more articulate in what he wants to say.
Right.
So I'll let Richard go first, if I may.
Apologies, Richard, your hand isn't showing on my screen. So, Richard.
Thanks, Chair. Yes, so I absolutely support that we ought to do a bit more due diligence in this area. We've got some data locally about the equivalent excess deaths among people in learning disabilities during the course of the pandemic, and John, happy to share those with you. And we ought to be asking ourselves the question whether there is anything more that we can do for this group of individuals. So yeah, happy to endorse. Thank you.
Thank you, Richard. And Johnny, can I bring you in now? Johnny, are you there? You disappeared.
Apologies. I've taken my hand down. It's all right. Thank you.
All right. Okay. Okay. Thank you. So, Gary Jones.
Yeah, just an observation, really. So we did a piece of work pre-COVID in Tamworth, which was around older people with health and care needs and looking at community capacity and community assets, and it was quite extensive. We've pretty easily found over 50 different social activities that older people could get involved in. We then did a very similar exercise for adults with learning disabilities, and it was much smaller. Less than half, far less than half of those same kinds of social activities, connections. So there's sort of some semi-quantitative but much more qualitative information there that sort of tends to indicate that social connections and opportunities for support outside of immediate carers is much narrower, I think, and whether that's potentially something around the kind of supportive communities agenda within the county and a kind of prioritisation of that cohort as that programme's beginning to look beyond its current priorities.
Thank you, Gary. Right, okay, so any other hands up? If you could just shout if you are. No, okay, so we've been asked as a Health and Wellbeing Board to note the evidence of the health inequalities for adults with learning disabilities dying, particularly from COVID-19, and asked to consider the findings with a view to endorsing and supporting understanding this the causes of this disproportionality and actions to tackle the determinants, which, as Richard says, he would endorse, and so I would look to the Health and Wellbeing Board to support this. Okay, thank you.
Chair, just before I go, can I thank the board for their consideration of this matter? I'm very pleased, of course, that there's a recognition that more needs to be done on this. So, from a safeguarding board perspective, we will continue to seek assurances in our normal way to move this on. But I have to say that since it was raised by the Safeguarding Adults Board, there has been some interest generated. So hopefully it will all come together and we'll see better outcomes for adults with learning disabilities. But thank you very much for your time today.
Thank you, John, and yes, that's very good to hear. And thank you very much, Ruth, for attending.
Thank you.
Okay, thank you. Okay, so if we could move on to the next agenda item then, and that's looking to Helen, who's just popped up on the screen. So can I hand over to you, Helen, then around the SEND strategy and the annual report from the Staffordshire and Stoke-on-Trent Safeguarding Children's Board.
Thank you, Chair. These are really items for information. Hopefully you will have noticed, for those who have seen previous Safeguarding Children Board's report, a significant reduction in size and scale. And hopefully focused on being far more kind of reader friendly and concentrating on the important things rather than providing you with 100 pages, I guess, of activities. This was the first annual report of the Stoke-on-Trent and Staffordshire Safeguarding Children Boards since it merged in April 2019. And I have to say it will be the only report of the Stoke-on-Trent and Staffordshire Children's Board for reasons I'll explain in a moment. I'm sure members of the board are aware of the legislation that came out in 2018 called Working Together around reviewing how Safeguarding Children Boards worked, recognising it was time to broaden accountability, but also streamline some local arrangements as well. Staffordshire and Stoke-on-Trent were successful in being identified as an early adopter by the Department of Education, and we had some support from them to do that. The reason that we were identified was it was the bringing together of two boards into a single entity, and nowhere else, I think, was proposing that at the time. So the board was up and running in shadow form prior to going live formally in April 2019. And I think it would be fair to say that what we've seen is real high-level buy-in across the three statutory safeguarding partners, which is the police, the CCG, and the local authorities. So 4 if you count the local authorities as obviously as 2, and real commitment to trying to make sure that the safeguarding partnership made a difference. That coincided more or less with the Ofsted inspection in Stoke-on-Trent of its children's services, which was not the best. So really the focus of the joint board over the first 12 months has been actually getting up and running, the nuts and bolts sorted, continuing investigating things like serious case reviews that were the legacy from the previous board, and any new emerging issues, getting in place a effective and streamlined performance framework, particularly monitoring performance against neglect issues and criminal exploitation, which were and remain priorities. But I guess principally focusing on Stoke's improvement journey and seeking assurance through that board that Stoke's children are increasingly safe, and that the difference that was being made was making a difference. I think we did that pretty well. Having said that, during the year, Stoke City Council, understandably, with its partners, decided that they really needed a board that absolutely just focused on Stoke's children and young people. So I guess we just got going, and then we were unpicking the arrangements that were in place. So we are now 2 separate boards for 2021, which is why this will be the only report of the joint board, although working in partnership still across safeguarding issues, particularly child exploitation, where we have launched a joint strategy. And today actually was the second all-day virtual conference where we had 200 plus people at the launch of that strategy to see how we can join up across the partnership to combat that as a safeguarding threat. I think it's pretty self-explanatory as a report, so it's here just for noting.
Thanks very much, Helen. So any questions for Helen? If you see any hands go up, Helen, then shout.
I'm on a split screen, so I'm struggling.
Okay, I can't see any hands gone up, so okay.
So do you do the second one?
Yes, please, yes.
Okay, so again for information, because we've brought updates previously around developments in SEND. This is for information. This is the Staffordshire SEND strategy, which has been approved by the Council's Cabinet in February and is going through the CCG's approval mechanisms at the moment. It is a strategy that has been produced in partnership with CCG colleagues, with schools, and with families and children and young people themselves. We had a widespread consultation process prior to the strategy being pulled together, albeit not quite in the way we'd envisaged, because the consultation period absolutely coincided with the start of lockdown, which meant access to children and young people themselves in the way that we'd initially planned was more challenging. But we used social media. We had Facebook Live events where we had 8,400 people visit, and we've had a lot of input from parents and those partners involved in delivering services for children with SEND. There's 4 priorities that have emerged out of that consultation and in the strategy, which is around improved communication, the education, health and social care work alongside and in partnership with families rather than doing two, and recognising families as equal partners who normally know the right things for their children, the right support at the right time, so an early intervention approach through graduated response, trying to retain as many children locally in their mainstream schools as possible to become an inclusive county, and that inclusivity extending to what's available in communities for children and young people with SEND as well. It's high level. I think it's quite simple and straightforward to read and understand, and obviously sitting underneath that are the detailed delivery plans around those 4 priorities. And that was all I was going to say, Chair.
Thanks very much, Helen. And certainly, I've been looked through the strategy from a CCG point of view as well, and can confirm that it's going through our Quality and Safety Committee this month as well for approval. Gary, I think that might be a new hand. Gary Jones? No, it's not.
No, it's
no.
not.
Okay. Oh, I don't know. Right, Teams. So, okay. So, unless there's any further questions, then for Helen, thank you, Helen, for presenting those two papers for information. Mark, Mark Sutton. I've got your hand up on the screen again. Is that an old hand?
Yes, it's a long time old.
I know. Yeah. Okay, thank you. It's gone down now. Okay, so thanks very much. So moving on to the final agenda item, which is the forward plan. And just to highlight the areas that are on the forward plan for the future meetings. So, as mentioned earlier, when Tony Bullock presented the public health plan, Tony will be coming along probably to the June meeting to give a more detailed and updated update on the plan. We're planning to focus on mental health as a key item, which is our second board priority, again in June. We're planning to invite Gary Jones and Phil Pusey to give an update on the state of the voluntary sector. We're also, as Health Watch is one of our statutory members of the board, it's been quite a long time since Health Watch has reported to the board, so we'll be inviting them. We'll also be bringing in a BCF update, further update on the integrated care system and integrated care partnership developments, and particularly how the Health and Wellbeing Board and the are part of that. And also we'll continue to update on the COVID situation and the impacts of that. So we had one item of any other business, so I'll just go through that now, but I haven't received any others. So as part of our statutory duty, the statutory duty of the Health and Wellbeing Board, we're required to receive the pharmaceutical needs assessment, which is a link in the papers. So we're asked to receive the report, and the key messages summarised are that 3 pharmacies have closed and no new pharmacies have opened. 7 pharmacies have changed address, 14 have changed ownership or name, but none of these changes are believed to be of any concern. Okay, so if we don't have any other items of any other business, then if I could say thank you very much for attending today and for all your contributions. And our next meeting is on Thursday, the 3rd of June. Again, it will be over Microsoft Teams. Okay, thank you very much, and hope to see you all soon.
Thank you.